Alright, this is recording now, and I'm going to change it to slideshow. I'll have to get my little pen ready. So we'll start recording from here, and we can delete the stuff in front of it. This is, I'm Dr. Bill White, and I'm going to go through this group on high angle cases. And they have dental closed bites, some of them are dental open bites too. And these are the difficult orthodontic cases, really, and they're probably the toughest to do, and some of them take a very long time, and sometimes you just can't possibly win without doing some orthodontic surgery on these cases. This particular case right here had some functional problems. Nearly all of these cases have some type of functional problem when they start off, and they'll have a narrow upper arch, and they'll have a tongue thrust or a mouth breathing problem. Some reason or other they hold their mouth apart, and their teeth erupt further toward one another, and then when they close their bite, their teeth come together and their chin is quite a ways from their nose, and this distance in here really messes up the appearance of the person. The chin would be better off if it were somewhere like out here. She has maybe a little shortness of the jaw, but if the bite were closed, it rotates around the condyle up here, and as it closes to it does like that, and the further it opens, the further it goes back. In fact, when you get to about 45 degrees in here, if you open a millimeter, you'll go back a millimeter to that particular angle. And then as you get further than that, you open a millimeter, you can go further than that. And so it makes the chin look really short on a person where they may have a fairly decent chin structure when they start out. Now this girl had several functional problems, and she's got a terrific gummy smile. That's one drawback, where the teeth are down lower. That's very hard. And if they breathe through their mouth, if people breathe through their mouth constantly, they keep their mouth open, and the lip doesn't come down as far as it will. Now, I've always told people, if you stretch your lip, try to pull your lip down over your front teeth, you can lengthen the lip. Now, when I was a little boy, my teeth stuck out, and I remember going to this Dr. Gillespie that my mother worked for about 25 years, and he did a labiolingual type orthodontics, but he had me stretching my lip down over my teeth, and now my lip is so long that it hangs over the edge of my teeth, so you don't actually see the teeth unless I kind of smile a little bit. So you can lengthen the lip if you want to, and that makes this less of a visual problem. And people that don't believe that will just go look at these platter lip people. They'll have their lips stretched way out like that. I mean, just tremendous lips. So I have people just stretch their lip over the edge of their teeth, and that'll lengthen it to some extent. Anyway, where if you smile like this, your lips just kind of come right above the tooth line, which is much better. Now, I don't have any concrete evidence of that, but other than just seeing these platter lip people and things that people do crazy to their tissue. If they put things in their ears, sometimes they keep getting it bigger and bigger. I've seen some of them with their earlobes hanging down like that. So you can stretch the tissue and do a lot of things with it. Now, this young lady had several problems. here is her dental models, and we've got a closed bite with a high angle case on this particular case. Now the bite's closed, and you can see how far the upper teeth come in over the upper laterals and everything like that. She had an unfortunate thing happened early on in her case where a crown was put on a deciduous tooth, and it formed a granuloma, something underneath this crown, and pushed the bicuspid way down into the bone structure, so we took teeth out. Now, you take teeth out on high angle cases if for nothing other than reduce the number of teeth that are coming together in here, and whatever muscle structure, muscle pressure we're getting is exerted on fewer teeth, and you can get the bite to close a little bit in that way. But the first thing is to correct the functional problem that caused the open bite to start with, whether it's mouth breathing, thumb sucking, or various things that people do. Excuse me. That opens the bite. So correct the functional things as fast as you can. Then you can reduce the teeth, the number of teeth, and that'll help close the bite. You don't want to dish the face in, so if you get further back in the mouth to reduce the teeth, you can close the space and really not dish the face in very much. If you get second bites, now in a lot of these high angle cases, we'll take the second bite and we'll go back and get the wisdom teeth out, or even I've taken, you take second molars. 6-year molars are real effective, but people are kind of reluctant to take out the 6-year molars and lowering the bite. But having excess vertical dimension of the face is one of the doggonest things for you just makes the face look bad. You just can't have a good looking face with a half inch of extra vertical height up there in the face. Okay, on this young lady we plan to take out the deciduous second molars, and we would go after the second bicuspid. So we're going to take 4 teeth, 2 deciduous in here and 2 permanent teeth on both sides of the mouth. One side of the mouth had the deciduous teeth. One of them was already gone, I think, over here. This is a permanent bicuspid that's in there, so we're going to take the deciduous tooth, and go after this one down below. All right, and we took out the wisdom teeth too, so I just marked that on there. So here we removed 8 permanent teeth to help lower the vertical dimension of the face, and tried to get teeth that wouldn't flatten her face too much, but she's got a fairly protrusive facial structure, so we didn't mind bringing it down to some extent. Alright, this is just looking at the upper model, and we've got a deciduous second molar over here we're going to get rid of, and we'll go after the bicuspid that's down there. And here the bicuspid is already in place, so we'll take it out too. On the lower mouth, the lower jaw, we had both deciduous second molars are still present, so we'll take them, and sometimes we take them and let the tooth come up some, but one of her bicuspids wouldn't come up, and I'll show you on the x-ray later. Now we've got a lot of crowding in the case also in here, so as we go back with this, we'll solve the crowded problem here in the front. That's not a big deal. So here you can look at the profile on the cephalometrics, And you see, we've got too much protrusion, so we really want to bring the face in some anyway. And we can bring these teeth back and these back some and reduce the vertical and reduce the profile, and that's good. If we'd had a flat face, it'd been a little harder to take out these teeth and come out with it without some type of reverse headgear. Okay, if we go in and look at the first Panorex that we have on this young lady, was taken in 1979. And to my I apparently saw this girl in 79, but I didn't do this work on her here. I have a Panorex. I don't know whether I got it from somebody else or not. But this tooth was abscessed right in here. And don't put crowns on abscessed teeth, because I've seen these teeth form a granuloma or something and push the developing tooth out of place. And that's what actually happened in this particular case. We'll go in here and get pull up another Panorex. Now this is 1985 and that was 1979, so that's 6 years later before I saw this girl back. Now this tooth had been crowned with a stainless steel crown right here. Now this had a stainless steel crown, but apparently didn't form a granuloma or whatever and push the tooth back. This one right here, the tooth seems to be retarded in its development coming down and hasn't eaten the root away properly, so it's stuck up higher than it should be. This one has gone up against the filling and the crown, and it's kind of stuck. This one apparently formed a kind of a granuloma or cyst-like formation here, and it pushed this tooth down out of position. Now let me kind of erase that and go back and look where it is, and look where it was 6 years before then. This tooth was sitting straight up and down in here, headed in the right direction, and if this had not been crowned, the material would have come out. You'd have pus or whatever would have come out through the tooth, but the tooth could have been eaten away by this when it come up. But by putting this crown on, just seal this off, and they probably put some filling material in there. I can't tell what filling material was put in there, but something was put in there, and then it formed a kind of a cyst in here, and it pushed this tooth down flat, and it was headed straight up right in here somewhere, and now it's shoved down and developing down here close to the cortical bone structure, which is not a good thing at all. So we came in and took, either I did or sent it to an oral surgeon to get that out. I don't know. Years ago I used to do the surgery for my orthodontic cases a lot of the time, but later on we sent nearly all of that kind of stuff out to oral surgeon or to the dentist, that, especially if somebody referred it, we'd send it to them to get the teeth out. So we took this tooth out down here, we took the tooth out above, took this tooth down here, and this, and one of them, the bicuspid, we just extracted the bicuspid, so there's a bicuspid gone from up here. Now the space, this is 1986, and the space is closing up. We've moved back, and the teeth are straightened out in there, and we've closed this down. We've extracted teeth back here. So I'm sure I sent this girl to an oral surgeon to do that. So here's 1986, and we're way along on our way in doing the case. Here's 1987. We've got a little space left. We need to bring these roots up a little more. In pretty good shape over here. Everything's lined up now. Somewhere in here she lost the nerve in that lateral. Let's see if it was, I don't. Well, it had a root canal on it over here too, so I don't remember exactly what was wrong with that lateral tooth to have a root canal done on that early age. She's 16 and a half right now at this time. Now here it is, 1987, and the space is pretty well together. We're just about to finish up on the case. And she's 18 and a half now, and I don't know, this is the sixth Panorex we've taken on her, and we've taken everything off the top, and we've still got 3 to 3 banded down on the bottom. I never did get this roots back where it should be, nor this one all the way, so that's our fault. We didn't put enough tip in the arch wire right there. You don't notice it till you take the pictures of it sometimes. So she's 18 and a half at this time, and here are some blown up pictures of that tooth. And this was 1970. I think this was 79, something like that, when we saw this girl. Then we didn't get her back in until 85 or something like that. It was about 6 years difference from here, and here's this kind of abscess tooth, and the guy crowned this thing. He must have put some filling in here and thought he took care of it, but a cyst or else an abscessed area. It probably was a cyst, so I don't think she had an abscess in there. And it took this tooth and just shoved it down, laid it right down. So here's what happened to that tooth. It's pushed down like that, and during this time the root grew, ran into the cortical bone, and kind of turned up like that. So all of this there's no bone to speak of in here. So when you extract this tooth, you can come down and get this. Now I have tried, and I've done one or two of these where you really needed to keep this bicuspid, so I had an oral surgeon come in and take everything out and clean this all out, and then just luxate this tooth right in here and kind of set it up where it's sitting, coming up something like, maybe like this, and where as it grew you could pull it up, or else you attach something to it. If it's already got the root on it, it's not going to be forced up as the root grows, and so it's best to kind of pull them up with something, but that takes a long time, and that's a very difficult orthodontic procedure to do. So in this case we needed to extract teeth, so we took all these teeth out on this young lady. Okay, we'll kind of look at this after we started the orthodontics. Here it's 1985, and we're taking some starting models, and we've done the extractions and all this. Prior to this, we went in real early and got all that stuff out and let her just sit there for a while. A lot of the space closed up. Normally we extract and start the orthodontics immediately, but she didn't have everything else in there quite ready. So here we are, we've extracted the teeth. They haven't been out too long, and part of this is already drifted together. And the crowded situation here, we're just going to back these first bicuspids up to about here, and then room for these to come in. I'm going to pause this just a minute. And now we'll start again here. Hopefully it paused. Okay, hopefully it paused in there. So now we've got all the appliances on. Looks like we've got rectangular arches in there, and we're put an intruding arch on the bottom. That's where this comes out with this little deal, and it'll be coming down here and raise it up. So we're lowering the lower anterior teeth. We're bringing them down. Now these are good brackets here. There's really a single bracket with these wings on them. Call them a Lewis bracket, and they work quite good. We stopped using it one time because stuff would get underneath here and cause decalcification around the tooth, but now you've got some real good sealant, so that would be a good bracket to use. You've got a rather large inner bracket space, which allows you to torque and bend your wire quite a bit before you put it in the bracket. So that's a pretty good bracket to use. Okay, so we're closing the space. As we're closing this, we're lowering this down, so we'll keep her in a class 1 anterior part as we close the space up. And you'll have plenty of space to straighten the teeth out, and we've reduced the tooth structure in there so it'll help bring the bite down. Now at this point we got a big midline deviation and probably got a little more class 2 on one side than the other side, so we'll have to come in here on this right side. We're probably going to have to wear a good, I see I've got a elastic hook up there. We're more class 2 elastic on one side than the other. The left side of the mouth looks like it's coming in pretty good into class 1. And this doesn't look bad from when you look at it from the side over here. Now the spaces are pretty well together, and we're moving on with the orthodontics. It's coming right on along, no problem. I've got this tooth down too far. This one's raised up. Really, I should have made this bend further over here. It's off center, so that made this tooth higher than that one. Now we've got tip in these teeth, you see. The roots will be angled out like that, and we put tip in these laterals too as we went back, and some in the cuspid. But we've got our bite open pretty good, and I'm showing a lot of slides on this. This is, if you wonder what we used and how we used it, you can kind of look at this very carefully and find out. Now we're back pretty close to class 1. On this side it looks like a good class 1 actually. Now the space up above is just about together, and you can see the tip that we built into this arch wire. Now the tip is a second order bend, and the in and outs are the first order. The third order is putting torque in if you wanted to torque the teeth. And we don't have any bands on the second molar, but the second molar is falling in place, and there's really no reason to put bands on it, you see. Alright, the lower arch, we've still got a little space to close, and you virtually always band the lower second molars and line them all up, and if you get them lined up good, the upper second normally will fall right in place up above it. Alright, here now we have finished the upper and taken it off and put a retainer in the mouth and let her wear this retainer. We still have a 3-to-3 deal on here, and I used to do this until I bonded a 3-to-3 on the back side. Now we just leave our arch wire in there the whole time until we bond the 3-to-3 on the lingual side of these teeth and get it in there good, and then take this off. See, and take all that off rather than take a chance of this cuspid or something drifting out before we can get the 3 to 3 on. So we put that on before we take that off. Now, okay, everything's in pretty good class 1, and overbite looks good, and it'll settle in. These teeth will drop into the mouth after a few months of chewing and everything, and they'll work out their position with the opposing teeth. Alright, here we put a retainer in the upper, and it's got a little bite plate. You can see where it touches it, so it can't deepen past that point, and that works out pretty good. So that's 1985, and here it is 1987. We were in the middle of treatment, and this is 85, and I don't have a date that I can see here. This is on further down the line. And we've still got way too much vertical height of the face. Not terrible, it looks better, and we've reduced it some, but it's not enough really, and that's another view of it. Now looking at it from the side, as she gets older here, it looks better, but we never did get it down. I wish the chin were about at this height and the chin would be out further, but that's about as good as I could do orthodontically here. So it's very difficult to really win these high angle cases, but it kept her from just looking really bad. And this is 1989. Doesn't look too bad. Maybe it's gotten a little better. She's certainly not dished in. She has a fullness of the face still. You know, it was too full when we started, and it's slightly on the full side when we finished after extracting all those teeth. Let me go back here and get the, so you can see she looks fairly normal, but you wish the chin were a lot shorter. If we could have intruded her teeth further. Now with tads and things, you might be able to attach up here, put elastic over and pick the molars up here and get the bite to close further down than what we were with just headgear. Now if somebody wore enough headgear, I could lower their bite, but they just won't hardly do that. Alright, this is another case coming up here, and this case I did not do. This lady had some really health problem that I don't really understand, but I'll show you her case when she was a kid. But this was a hideous situation developed on this young lady. I mean, she just didn't grow a jaw. It really is pretty bad. Now, the jaw didn't grow, and it just stayed back, and it just really ruined this lady's looks. Now, whether they could surgically come in and build her a jaw, I don't know, but orthodontically, I didn't see any way I could possibly correct this. These are some earlier pictures of her she brought me. It wasn't quite as bad here as it was back there. So this was when we saw her. But these pictures were taken a little earlier. Now when I x-rayed her, the condyle is up in here and the jaw is just straight off from it, you see, like that. And that is bad news. I don't know how I could have done anything orthodontically. And the bite's kind of open. She could chew and everything, but hideously looking facial structure. They might could do something surgically for her, but I didn't think I could do this. These are some dentists that she had gone to before she came, and I just looked at her and took some records on her and took some pictures. But this is what can happen to people. You know, the condyle just thing just straightened out back here, and very hideous situation. On this side, the condyles just lean way back in here. You see, it looks terrible. Now, this is her when she was in school. She brought me these school pictures of herself, and she's a neat little girl. You know, looks quite nice. And here she's got a good chin, good facial structure, lip structure, everything looks good. And it looks good here. And this picture's nice. There she is as a little girl. She had a real good chin when she was just a baby. Pretty little thing. And here she is later on. And it's kind of beginning to show some signs here. There's a little excess vertical developing, and her bite opened like that, and from there it went on from bad to worse. And I never did treat this girl, but I thought I'd just put it in here and show you what can happen to people from time to time. And this is the last picture I had of her. Alright, here's another young lady that came to me, and we worked on this girl for years, and she had way too much vertical height. Now this one we really won out, and we got to her in time, and we stopped the breathing problem, and everything, got her functioning good, and got some teeth out, and lowered the vertical height of the face, and it comes out looking pretty doggone good. Now, her teeth looked hideous when she smiled. That one central was sticking out there like a sore thumb. And she, of course, this is affecting her personality and everything else. If you just look at this part of her face, she looks quite nice looking young lady. So we needed to get on to this. And you start something like this just as soon as you see it. You know, you got to correct the functional problem and get that taken care of, and then start in on the dental, or you start them both at the same time usually. So this was a kind of a hideous case to start off with. And I have these models, and you show them this because this is going to drag out, you see. You just got a long-term case, and you've got all these baby teeth, and you have to work on the front of it for several years before they lose these, and they think you're taking too much time in here. Now, this is after starting the treatment a while, and we wore an occipital headgear that's kind of pulling back like that. Now you can cut the arm of the of the headgear. You can cut the face bow off, so that you're picking up more toward the molars, or if you back here, you pick it up the back end of the arch wire, raising it up like that with an occipital type headgear. And we've got to intrude the molars to some extent doing that. We got that tooth lined up, and she's looking better now than she did. This is 1974, and we'll pull those two teeth together, and we, if I remember correctly, we went in and took some bicuspids out on her fairly early. Now this is back before we actually went into full brackets, you see. So we've got these teeth lined up, and we've extracted, I'm pretty sure, the first bicuspids at this time. Now we're wearing an occipital headgear. It's hooked into the molars back here, and if you cut those arms off about at this level and you pull it up, you'll kind of pick the molars up. If you cut them shorter than that, you pick up everything in between. You can make them real short, and you'll just pick up the anterior part of the mouth. So an occipital headgear is a good tool to use in orthodontics. So we see these people running around bragging because they never use a headgear. Well, they have some cases that don't look as good as they could if they went ahead and used the headgear. Okay, so we've got to open the bite, and this is a year after we started the treatment. She looks a lot better, but she's still got a lot of baby teeth in there, and it's going to take a long time to do this case. Seemed like we worked on her about 6 or 8 years before we totally had it finished. Now she's beginning to look quite good, really, and that's not really bad. And we've got the bite lowered to some extent here. I don't know what these spots on her face are, but anyway, that tooth is sticking way out. The gum line isn't lined up, so somewhere during the treatment you bring these two teeth together and torque them, and have the torque the same, and then you can trim a little bit of the gingival tissue to make it balance out in there. So right now this tooth needs the root torqued in. It needs this part of it brought in like that, and bring this underneath the tissue better. And you may have to take a little of this off up here to make it look really good. Excuse me. Alright, let's continue on. We just got a 2x4 upper appliance in there, just 6-year molars and the 4 anteriors. We've taken out the first bias on the case and getting her breathing properly and functioning properly. And as we do that, we create enough space down on the bottom. Alright, here's 1977. We've been in it 3 years now at this point, and we had to start and stay with it, so it's going to be a long-term case. And we're wearing some class 2 elastics, which is not the best for high-angle cases, but you can do that, and we probably wore some occipital headgear continued with that. And these were all bands back in the good old days when we banded everything. It was the devil. To do orthodontics was tough. Alright, now we've got the 12-year molars in and everything's going along. It's 1978, and we've got just a little space to close up above. Alright, let me see. I think it's 4 3/4 years of treatment before we got to this point. Alright, we have her pretty well lined up here. And I think we got these off at about 6 years. We pulled it in place, and then we had her wisdom teeth, if I remember correctly, taken out. Alright, there's the models of the teeth when we started out, and here it is later on down the line. This is 4 or 5 years later. And there it was, the 1973, and this is 8.5 years. It took a long time for her to get her teeth in her mouth, and they were getting pretty irritated. They got irritated with me because you couldn't finish it till you got the teeth in the mouth, and that kind of hacked me off. They were griping about it. I had to show them what they looked like prior to that. And here's the way she looked in 73, and there it is in 82. So this is a long time getting to this point. But the little girl did go on and get to be a cheerleader. The mother came fussing at me, "Get these things off. I want her to be a cheerleader," and all this. And so finally we did get them off, and she looked quite nice and did get the position of cheerleader. Here's a bite plate with a upper retainer with a bite plate. We still had it over the 6-year molar band, so we could wear a headgear if we saw our class 2 slipping. Well, we could come back with a headgear on it up there. Alright, the bottom looks quite good now, and I'm sure we had the wisdom teeth out, and there it is in 73, and that was the bottom arch. I guess that's 82. Said I don't know how long it's been off at that time. That's 82 again. And here's the young lady's face after we finished. It's quite a good looking young lady. And her mother was griping at me to get these things off, that our neighbor over there was only in braces for 2 years or something, and you've been keeping these on my daughter for all these years. You wanted to hit her with something. Well, the little girl went off to college and studied, I forget what it was, but she had a little more sense, and she came back by the office and thanked me for doing the orthodontics on her. And her smile is pretty. She's got a little bit of gumminess to the smile, but not severe. Quite an attractive smile. I would like to show a little less gum treatment, but I mean gum. Anyway, that's one more high angle case that we've done here. I'm going to pause again. I can pause. This doesn't seem to stop on anything. So we just have to cut some of this out of the picture. I don't know what to do to pause it. That F9 didn't have much effect on it, that I could tell. Okay, I'm going to go into this next case. I'll push this, and I'll come back up here to stop this for the time being.